Okay, good morning, afternoon or evening, whatever time it is when you're watching this video, and welcome to Professor Tejan's kind of revision pub quiz that I would have delivered at the end of this module as a group, but as it is, you can, or we can do this over a video. So if you're going to take part, you're going to need a piece of paper and a pen. If you want to replicate the exact conditions I use for this sort of quiz, you will also need some sort of timer and give yourself 30 seconds between questions. You'll need to pause the video between questions. I don't ask the question and then sit there in silence for 30 seconds and then ask the next question. I ask the question on this video and move straight on to the next one, so you'll need to pause it once you've got all the possible answers. It's a multiple choice quiz, as I perhaps should have mentioned at the beginning. There will be one or two questions where you will need to give yourself slightly more time, but I will point those out as we go. There are, I think, 18, 19 questions in total, something like that, and we will go through the answers at the end and discuss them in detail at the end. Okay, so you can pause here, get yourself ready, and then we will begin with, rather logically, question 1, which is: arrange the following features of the gait cycle, this is the walking gait cycle, I should have added there, into the order in which they occur. Mid-stance, pre-swing, flat foot, contact response, and heel off. You need to rearrange those into the order in which they logically occur during a typical walking gait cycle, and therein you have your answer. Okay, question 2. What is passive insufficiency? Is it A, limited agonist muscle range of motion due to a restriction in the antagonist? B, limited antagonist muscle range of motion due to a restriction in the agonist? C, increased agonist muscle range of motion due to a restriction in the antagonist? D, increased antagonist muscle range of motion due to a restriction in the antagonist? Okay, moving on then to question 3. Which of the following models is used to describe the walking gait cycle? Is it A, the inverted pendulum model? B, the reverted pendulum model? C, the diverted pendulum model? Or D, the perverted pendulum model? Think long and hard about this one and come up with your answer. Okay, moving on then to our next question. What is the resultant moment produced at the elbow during the eccentric or lowering phase of a barbell curl? What is the resultant moment, so the overall moment, the final moment that is produced at the elbow during the eccentric or lowering phase of a barbell curl? Is it A, extension or an extension moment? B, an abduction moment? C, a flexion moment? D, an adduction moment? Okay, moving on. Which of the following is the correct equation for joint power? Is it A, torque or moment divided by angular velocity? B, force multiplied by radius? C, force divided by radius? Or D, torque or moment multiplied by angular velocity. So which of those is the correct equation for joint power? You could also rephrase it to say angular power, but I've chosen joint power because that's what you've been given with your data for your written report assessment. But they're the same thing. Okay, moving on to the next question. I've forgotten where we are already. Question 6, I think. Which of the following is not a causative factor for increased anterior pelvic tilt? So which is not a causative factor for increased anterior pelvic tilt? Is it A, tight hip extensors, B, weak hip extensors, C, tight hip flexors, D, tight erector spinae? So which one of those is not linked with increased anterior pelvic tilt? Okay, moving on. Which of the following is not a component of knee valgus? A, femoral or hip adduction, B, tibial or knee abduction, C, femoral or hip abduction, abduction, or D, internal femoral or hip rotation? So which one of those is not a component, or you could say a feature, of knee valgus? Doesn't have to be excessive, just knee valgus. We all experience a small amount of knee valgus, but which one of those is the one out that doesn't contribute to it? So for this question, you'll need to give yourself a minute if you're playing along at home. Which of the following images indicates a patient with tight calf muscles? A, B, C, D. So which one of those joint moment graphs indicates they're each from 4 different patients and 4 different people that have had a gait analysis over the years? Which one of those suggests someone that's got tightness in the calf muscles? Okay, moving on. This will also require a minute if you're playing along at home. Which of the following images most likely indicates a risk of a repetitive stress injury? Okay, just indicates, not necessarily confirms, but just suggests that there might be the person who produced this graph might be at a risk of a repetitive stress injury. So we've got A, B, C, D. So a bit of variety there. Pause, have 1 minute. Which one do you think? And I would emphasize with this question, which is most likely. There might be 1 or more images that would suggest a risk of a repetitive stress injury, but there's one that is most likely going to indicate it. Okay, moving on to an old favourite, which I know you've had before, but I just love including it. Which of the following is Manos's favourite lunchtime meal? Is it A, spanakopita with cubed feta, B, fasolada soup? I can't help but do the accent. I think I'm going Italian, but never mind. C, sun-dried octopus, D, wet bread. Bearing in mind he has had all these at some point or another in the office for lunch. One of the many reasons I'm glad I'm not in the office right now. Okay, moving on. Which of the following is not one of the 3 hallmarks of an inefficient gait? You could also say which of the following is not one of the hallmarks of an economical or an uneconomical gait. A. Bi/unilateral muscle asymmetries. You could just say muscle asymmetries if you want, but both. So a uni or bilateral muscle asymmetry. B. Reduced swing leg economy. C. Poor step-to-step transition. D. Increased flexion in stance. So which one of those is not one of the hallmarks of an inefficient gait? Which of the following is not a feature of overstepping running gait? Which of the following is not, there's a lot of these not questions in here, a feature of overstepping running gait? Is it A, increased knee extension at initial contact? B, increased hip flexion at initial contact? C, increased step length? D, increased cadence? So 3 of those are associated with the overstepping gait we see when people run. 1 of them isn't. Which one is it? Okay, moving on. Which of the following skeletal muscles does not contribute to propulsion when running? And I originally wrote this question as which one of the following skeletal muscles does research indicate does not contribute to propulsion when running, but it was rather wordy, but based on what the research currently tells us, it's not a muscle involved in propulsion when running. Is it A, gastrocnemius, B, quadriceps femoris, C, gluteus medius, D, the soleus? Which of those isn't a propulsive muscle? Okay, moving on. Which of the following are kinematic features of patellofemoral pain syndrome? Which of the following are kinematic features of patellofemoral pain syndrome? A, decreased stance knee flexion. B, increased internal foot rotation. C, increased hip adduction. D, decreased stance ankle extension. And I should probably clarify, I've hinted at it here in the question, which of the following are kinematic features? There may be more than one of those options which applies. In fact, there are, but I'm not going to tell you how many. So which 2, 3, or maybe even 4 of those features of those kinematic movements is a feature of someone with patellofemoral pain syndrome? Okay, let's move on. Bit of a wordy one, this one. The following theories attempt to explain why stretching increases joint range of motion. However, which of these has the most empirical evidence to back it up? So you could rephrase this to say, which of the following theories is currently accepted to be the reason why stretching increases joint range of motion? A, stretching lengthens the muscle connective tissue, for example, collagen. B, stretching enhances the stretch reflex and suppresses the Golgi tendon reflex. I forgot to put reflex in there after stretch. C, Stretching suppresses the stretch reflex and enhances the Golgi tendon reflex. D. Stretching suppresses the stretch reflex and lengthens the connective tissue, again, e.g. collagen. Which one of those theories is currently the accepted one to explain why stretching increases joint range of motion? Okay, moving on. Lateral winging of the scapula indicates a weakness or damage to which muscles? Is it A, the trapezius and serratus anterior, B, the rhomboids and serratus anterior, C, the trapezius and rhomboids, D, the rhomboids and the internal rotator cuffs? So which of those muscles, if weakened, would produce lateral winging of the scapula? Okay, moving on. Weakness or damage to the hip abductors, abductors, just to emphasize that there, can lead to which compensatory gait pattern? Is it A, the steeple gait, B, the Trendelenburg gait, C, circumduction of the hip, D, the quadriceps avoidance gait? Weakness of the hip abductors will cause which compensatory gait pattern? Steeple gait, Trendelenburg, circumduction of the hip, quadriceps avoidance. Okay, let's move on. Chronic pain on the lateral side of the knee could be caused by which of the following? Is it A, iliotibial band syndrome, B, quadriceps tendinitis, C, patellofemoral pain syndrome, or D, tensor fascia lata tightness? And that is your final question. So when you're done, if you want to swap your answers with someone else in the... Oh no, sorry, I'm having flashbacks to being in a lecture. Let's now go through the answers. So, question 1. Arrange the following features of the gait cycle into the order in which they occur. Doesn't really require too much explanation, but the correct answer was contact response, flat foot, mid stance, heel off, pre-swing. Yeah, as I say, not really much to add here. Pre-swing should have hopefully been fairly obvious. Contact response is a phase in between initial contact and flat foot, where the ankle slowly plantar flexes due to the eccentric lengthening of the tibialis anterior, and the other ankle flexes. So that leads to the ankle going from heel strike into flat foot. So naturally contact response precedes that. We then move into mid stance, and after mid stance the next feature would be heel off, where the heel is just about to come off the ground, and then that is followed by pre-swing as we just go into the swing phase. Not too much to say there. Okay, so question 2. That's just 1 point for that, by the way. You don't get a point for each one, it's just 1 point for getting it right. You either get it right or wrong. What is passive insufficiency? It is limited agonist. Oh, I haven't changed the idea. I corrected the responses, but never mind. It was A, nonetheless. Limited agonist range of motion due to a restriction in the antagonist. So I initially had and agonist joint wrong, but I thought it was a bit wordy, so I took it out and realised I didn't take it out in the answer section. Apologies. But Passive insufficiency refers to a restriction or a tightness in the antagonist muscle around a joint. So let's say the hamstrings, for example, which if they're restricted and if they're tight, they don't so much influence their performance. So let's say in the case of the hamstrings, knee flexion, but they are going to hinder the opposing motion by the agonist muscle. If let's say you're kicking a ball or walking, which would be the quadriceps, they're going to limit knee extension. So because the antagonist is restricted, the agonist muscle range of motion is restricted, and therefore the joint motion is going to be reduced as well. Okay, question 3. The answer was the inverted pendulum model. Not much to say here either. So this is the model that has been doing the rounds for quite a while now, that explains the human gait cycle based on the movement of the centre of mass over the stance limb from one leg to the other. And it looks like, if you imagine a pendulum in a grandfather clock, it looks like or it produces a pattern similar to that pendulum if it was flipped upside down or inverted. So hence inverted pendulum model. There's been a few revisions to it over the years and a few things that have been added and changed, but that is the original theory and that's how it's explained. Okay, the next one I think is going to throw a few people off, but here we go. What is the resultant moment at the elbow during the eccentric or lowering phase of a barbell curl? The answer is, drumroll, A, an extension moment. Now, I know what you're thinking. I've probably created some rage in a few of you there. Well, it's a flexion moment, surely. Let's just say biceps brachii is producing a flexion moment, but if the arm is moving into extension, that means that the extension moment that's being produced by the weight of the barbell has to be greater than the flexion moment being produced by the muscles, the elbow flexors. Yes, there is going to be a elbow flexion moment in there, but if the flexion moment was greater than the extension moment, then we would see flexion. If the extension moment is greater than the flexion moment produced by the muscles, then we would see extension. So the answer is extension. That would be the resultant moment. I hope I haven't enraged too many of you there. Okay, the next question was, which of the following is the correct equation for joint power? And that is, or angular power you could say, and that is torque or moment multiplied by angular velocity. This is simply the angular equivalent of linear power. Linear power is force multiplied by velocity. So a torque is a rotational force, and angular velocity is the angular equivalent of linear velocity. So it's basically the same equation, but with angular factors plugged into it. So the answer is D. So which of the following is not a causative factor for increased anterior pelvic tilt? It is tight hip extensors. Weak hip extensors would pull the pelvis, would allow the pelvis to move into anterior pelvic tilt, but that will only occur if the hip flexors are tight and are pulling the pelvis forward, and tightness in the erector spinae muscles, the lower back muscles, would also pull the pelvis anteriorly. Tightness of the hip extensors is going to cause posterior pelvic tilt, or certainly contribute to it in the force couple. Remember, the force couple that occurs around the pelvis, it's not a pathological phenomenon. We have basically a
force couple that is produced by the abdominal muscles and the hip extensors, which pull the pelvis posteriorly, and the hip flexors and the erector spinae, which pull the pelvis anteriorly. And as long as they are balanced, then the pelvis is maintained in a neutral position, which for humans is actually in a slight, about 15 degrees, I think, off the top of my head, position of anterior pelvic tilt, but excessive anterior pelvic tilt would be caused by B, C, and D. So the answer is A. Which of the following is not a component of knee valgus? The answer is C, femoral or hip abduction. For valgus to occur, valgus is much like dorsiflexion. It is a movement that is comprised of various other movements. It's a resultant movement, you could say. So for valgus to occur, we need the hip or femur to adduct, I should say, adduct. So move inwards towards the midline, and to rotate internally by a few degrees, and because of the position of the femur, then that forces the tibia or the knee into a position of abduction, abduction, so moving outwards if you think of the position of the tibia relative to where it was. Femoral or hip abduction would be an indication of varus. Okay, which of the following images indicates a patient with tight calf muscles? The answer is B. So the reason we would think this person perhaps has tight or restricted calf musculature is because of the initial peak that we see above the normative value there on the graph, in this joint moment graph. So there is an excessive amount of plantar flexion, or of a plantar flexion moment being produced there, more than we would expect. C and D are below and A to an extent are below the norm for part of the gait cycle. C particularly is below what we would expect. So this is someone with very perhaps excessive range of motion around the ankle. B and D, there's a slight increase at the end, but there is nothing abnormal, or overly abnormal I should say, that would suggest a restriction in the calf musculature, the plantar flexors. So B is the answer because of that large peak that we see early on, suggesting that there is a very large eccentric plantar flexion torque being produced that is followed by a concentric plantar flexion torque in the second peak in graph B. Okay, the next one was, which of the following images is most likely to indicate a repetitive stress injury? And it would be B. A would also be indicative, so C and D have nothing to do with repetitive stress injuries based solely on the information that we have here, so we can rule those out straight away. The area of interest on A and B would be this increased vertical ground reaction force during the first active peak. Not only that, it's occurring much earlier than it should do based on the normative values, so the loading rate is dramatically increased. If you look at the gradient of the line that the patients produced on the blue and red lines, that is far steeper than the normative values which you see there in grey. The reason why B would be a better image to use is because it gives us a bit more information, because if you compare in figure B the first active peak to the second active peak, there is far more inconsistency in the first active peak than there is the second, suggesting that there's possibly a stability issue, possibly it's basically the body doesn't know what to do, or this limb is struggling to compensate or respond to this excessive vertical ground reaction force. So B would be. A would also, if your answer was A, you were close, but B just gives you that bit more information, is therefore more relevant. Okay, so what is Manos's favourite lunchtime meal? It is, of course, wet bread. Many's the time I've gone into the office kitchen and found a few slices of Hovis just sitting there in a plate of water, and gone to throw them out, and Manos coming, no, it's my lunch, no, it aids my digestion, I do not digest starch well. Okay, moving on. Which of the following is not one of the 3 hallmarks of an inefficient gait? It is A, bi or unilateral muscle asymmetries. B, C and D are verbatim the hallmarks of a inefficient gait. If you look at your week 2, I want to say, lecture slides, I forget now. An uneconomical or an inefficient gait is characterized by reduced swing leg economy, so wasting energy during the swing phase basically, poor step-to-step transitions, not making the most of the momentum that's gained towards the end of the stance phase and carrying that over to the beginning of the stance phase on the opposite limb, and increased flexion about any limb, could be all, could just be one. This one is obvious. If you could try it yourself now, stand up and walk around in a half squat position, you'll realise how hard it is. That's an exaggeration, but it goes to show the importance of overly excessive flexion and maintaining the right amount of flexion to ensure an economical gait. Bi and unilateral muscle asymmetries may have something to do with gait economy, but not enough is known, and therefore they are the odd one out. Okay, which of the following is not a feature of the overstepping running gait? It is increased cadence. In order to overstep, we're basically increasing our stride length. So to do this, we would need greater hip flexion, we would need greater knee extension, and that's going to increase our step or stride length, either or. However, if you increase your step or stride length, that's going to decrease your cadence, which is the number of steps per minute or per hour or whatever you like, whatever unit of time you wish to use. So increased cadence just doesn't make sense. It would actually reduce the cadence. So A, B and C are features of the overstepping gait. D just doesn't make sense basically, therefore it is the answer. Okay, the next one I think is going to also cause some rage. Which of the following skeletal muscles does not contribute to propulsion when running? And I want to clarify this is based on the most recent research. From the answers A, gastrocnemius, B, quadriceps, C, gluteus medius, D, soleus, the answer is the quadriceps, for the main reason that the quadriceps are throughout the entire stance phase more or less in a position of active insufficiency. Obviously they bring the leg forward, or they position the foot forward during the swing phase, but the quadriceps during the stance phase are mainly there for stability. The gastrocnemius and the soleus are your primary propulsive muscles, and it's been shown that the glute medius plays a tiny role in propulsion, but still more so than the quadriceps, which is there just to keep the knee stable and to keep your body upright. So almost a bit of a red herring there, C, but nonetheless the quadriceps femoris doesn't appear to contribute to propulsion. during the stance phase, and propulsion doesn't occur during the swing phase. You're just moving the leg forward. Propulsion is what occurs during the stance phase. I'm sure there's a few of you furious at me now. Okay, the next question: which of the following kinematic features kinematic features of PFPS? Primarily a reduction or decreased stance knee flexion, and that is as a compensatory gait feature to prevent the knee from obviously flexing too much during the stance phase, which increases the contact pressure between the patella and the femur, and I had to sneeze. Increased hip adduction is sometimes associated with PFPS, mainly because it's a feature of valgus, but not always. A would be your main feature, C occasionally. The other two, B and D, have nothing to do with it whatsoever. So, our wordy question: the following theories attempt to explain why stretching improves joint range of motion. Which of them basically is the most accurate, and which is the currently most accepted one? It is, drumroll, C. Stretching suppresses the stretch reflex, which makes sense when you think about it. You're suppressing the stretch reflex, and enhances the Golgi tendon reflex. The Golgi tendon reflex tries to relax the muscle that is being stretched, and the stretch reflex tries to increase the tension in the muscle that's being stretched. So if you reduce the stretch reflex and enhance the Golgi tendon reflex, then that is going to cause or going to facilitate a more effective stretch. This is the physiological theory of stretching and why stretching works. A is the biomechanical theory, which I'm sorry to say isn't currently the most accepted. Furious. Okay then, so lateral winging of the scapula indicates weakness or damage in which muscles? Drumroll, it is C, the trapezius and rhomboids. Mainly the trapezius, but the rhomboids can be associated with lateral winging, obviously because of their position and their sites of attachment. But the serratus anterior, if it was tight, would cause lateral winging. Sorry, I lost my place. But we're talking about which muscle if it was weak or damaged. So the serratus anterior can be ruled out straight away, and the rotator cuffs, the internal rotators, don't have anything to do with those. So the trapezius and the rhomboids, mainly the mid and to some extent lower trapezius, but mainly the mid trapezius. Weakness or damage to the hip abductors results in Trendelenburg gait as a compensatory gait pattern. Steeple gait is something we tend to see if there is an issue with the ankle flexors, so the dorsiflexors, so the foot is in a position of plantar flexion during the swing phase, just hanging down. Therefore, steeple gait is where we see excessive hip flexion. Circumduction is another, it's a compensatory gait pattern actually for a few different I don't want to say pathologies, but a few different conditions. But that could also be a compensatory gait pattern for an issue with the ankle flexors, and quadriceps avoidance gait is a gait pattern that we see because someone's trying to avoid using their quadriceps. So the answer is the Trendelenburg gait. Okay, and the final question, which a bit of a red herring here, almost kind of a trick question, kind of not, I suppose. Chronic pain on the lateral side of the knee is caused by which of the following? It is iliotibial band syndrome, which is caused by tightness in the tensor fascia lata, which is an anterior hip muscle. I say is caused, it's sometimes caused by issues with the tensor fascia lata being tight. Not always, but sometimes. Quadriceps tendonitis is usually associated with pain below the knee, where in the sort of the region between the tibial tuberosity and the patella. Patella femoral pain syndrome is anterior knee pain, so pain on the outer side of the knee. Iliotibial band syndrome, and one of the causes could be the TFL being tight. Again, apologies for the trick question, but there we go. So add up your answers, and if you've done well, give yourself a pat on the back for being a good student. Shame that your last lecture with me has to be in this format. It's been a pleasure, and I wouldn't say this if it wasn't. It's genuinely been a pleasure teaching you all over the past few years, and I will see you all in your Viva Voce, which you've got coming up soon.